Hi everyone, welcome back to the Monthly Truth. Today I'm joined by someone pretty special, Dr. Milli Raizada. Not only is she a trustee and ambassador for the PMDD Project, but she's also a doctor, an expert in lifestyle medicine, and to be honest, just an all-round powerhouse when it comes to women's health. Dr. Milli has published her very own book, Happy Hormones, Happy You, has delivered a TED Talk on hormone health, and has set up her own GP practice, Dr. Milli Health Clinic. We're going to dive into all things hormones, health, and the stuff that really matters when it comes to feeling our best. So, welcome, Milli.
Thank you very much, Phoebe. Nice to see you and nice to have me on.
Yeah, thank you so much for joining us. It's an absolute pleasure to have you on the board as an ambassador and just to sort of pick your brains today. And I always try and start the interviews by asking this question, and I'm really intrigued to hear your point of view with this. So, in just a few words, how would you describe PMDD?
So, PMDD, premenstrual dysphoric disorder, I would describe as a hormonal sensitivity disorder. So, blood tests aren't required for a diagnosis, but if we were to test people's hormones, they would be of a normal level, but it's the way that people react to those hormones. So, even though people say it's not a severe form of PMS or premenstrual syndrome, it is a severe form of it in the way that you get severe physical and psychological symptoms in the luteal phase, which is the 2 weeks before your period, but it can seep into the first week of your period as well. And the thing with it is that it's long term, so it's chronic, happening cyclically, and it's recurrent as well. So they're the kind of main features of how you'd actually describe it, because people may have a mental health illness like OCD or depression or anxiety, which can get worse in that luteal phase. And so it's very important to try and distinguish between that and PMDD, if that makes sense.
No, I think that's a really good way to describe it as well. And there's often like a big misconception between PMS and PMDD too. So it's good that you've outlined that. And obviously you've got over 15 years experience in the NHS. What's led you to focus on women's hormonal health? Because I know that you've got your own experiences with hormonal challenges, including PMDD. How has that shaped your approach to medicine and patient care?
So it all really started, and I think a lot of female founders have the experience where they've gone through their own personal journey, which has made them want to take forward what they're passionate about. So I was in a period of burnout and really suffering with my hormonal health, but I very much felt dismissed and gaslit by my GP. I didn't feel like I was being understood or heard. They were very lovely, and they were saying that it was mainly stress and I was doing too much, which I do take on too much. That's just the type of personality I am. But there was a hormonal element to it, and it was very cyclical, the way that I was reacting and responding, and that wasn't picked up. And it was really, I went to medical school, I did very well, I came top female in my cohort, but I don't ever remember PMDD being as part of the curriculum. I don't ever remember learning about it. I remember premenstrual syndrome, but never PMDD. And then I paid privately to see a specialist, and I walked into the room, burst into tears, and just within a few minutes of me entering the room, he kind of diagnosed me with PMDD, and it was just that light bulb moment of someone's listened to me, or someone's acknowledged that there is a cyclical kind of component to it, and it is related to my hormones, because I always knew it was. And so because of that, I went through the medical menopause for short of a year, I think it was, and then came off those injections, started back having my periods, and then symptoms recurred. But the medical management of PMDD, or kind of or the typical guidelines of the process of how we manage it, is very much, here's the pill, here's perhaps some form of HRT, here's an injection to stop you having cycles, so putting you through the medical menopause, and then further down the line, like removal of your ovaries and womb potentially. And there was just kind of no middle ground when I said to them, well, what can I do? There must be something I can do. And there was no kind of explanation of anything I could do to help and empower myself. So that's what led me down to reading all the research, looking into lifestyle medicine, like root cause functional medicine, really, to see what was driving my symptoms. And that's kind of led me to, I felt like in the NHS, it's a great service there for sick health care, But for preventative and for promoting healthcare and looking at ways we can prevent people getting to that crisis point, I didn't feel like in 10 minutes I could achieve what I wanted to. So that's what's led me to open the clinic, which is great because I can see people I mean, I always run late. So I'm on the phone to people for over an hour, having consultations. And it just means that we're getting to the root cause of the problem. Even that 1 hour is so therapeutic to them because they feel heard, they feel listened to. So I can't remember what question you asked me, but I have waffled on.
No, no, it's really interesting. And I think it's so important to highlight the fact that your clinics do offer that, like you actually want to get to know the person who's come into your room, who is, who you're having that consultation with. Because I think with PMDD and other women's health conditions, it's not just a tick box for getting that diagnosis and giving them the help. It's not just, right, take this pill and off you pop. It's just not. And I think I'm not alone, and you're not in the sense that our experience with getting the diagnosis in the first place and then getting the correct treatment has been so difficult
Mm.
for many different reasons. And I know you've kind of alluded to the fact that, and it's really interesting that you actually never learnt about PMDD when you were at school. It's actually when you were at university. It's taken your own research and your own experience to learn more about it. But what obstacles do you think then do patients typically face in obtaining a PMDD diagnosis, and how do you think that healthcare professionals can improve this process?
So I think obviously GPs are the primary point of care and access for patients, and they are excellent. They're in a underfunded role and high pressure. So I've been there. I understand what that's like, and we have guidelines that we should follow, and obviously think outside the box. But because there's such little funding for women's health, and because it takes so long from when research has been done for it to be implemented in kind of clinical guidelines, and because there's limited training, looking at the medical curriculum, these are all kind of barriers to education for medical students, GPs. And so I think when we're feeling dismissed and gaslit, I think it's the lack of education amongst the GPs because of those issues. And I think that is changing. I think there's a lot more campaigns, a lot more awareness around the need for acknowledgement of this. The women's health strategy, the document, it's highlighted areas and where there is weakness within the system, where people are struggling, whether it be endometriosis, PMS, PMDD, and other women's health conditions that are being completely ignored, really. Vulvodynia, there's so many, but yourself, PMDD, it can take 10 to 12 years for a diagnosis. People can see 5 different healthcare professionals. And I think, just the charity itself, doing awareness sessions to GP trainees, I think these are the steps that it's baby steps to take to make change, so that people are just more aware of it. So when they're seeing the patients, they can start thinking, oh, could this be related to their hormones? And when I did my TEDx talk, it was very much trying to educate both the public and healthcare professionals of how they should approach seeing a woman. And someone comes in, we check the temperature, check the pulse, but why do we never say, what stage of your menstrual cycle are you in? We never ask that question. And for me, it should be a vital sign. It should be that 6th vital sign that we ask, so that it's always on our radar. And whether it's worsening of gallbladder symptoms or recurrent styes or urine infections, there could be that hormonal link that we're just completely missing.
Yeah, definitely. And that kind of sort of leads me on to my next question as well. What do you think are common misunderstandings then about PMDD? I mean, that's probably a really trigger loaded question, but how can public education maybe address these myths?
So I think there's a lot of myths around it just being a woman being hormonal and something that they should get on with. I think there's that, and it's still said now. The first line of my talk, I mentioned, people describing women as just being hormonal, and that, and it is a myth because men and women both have hormones, don't they? So I think with PMDD, I think when you've not experienced it, it's very difficult to relate to it, as it is with other medical conditions. If you've never experienced it, it's very difficult to relate to it. I think it's understanding the significant psychological impact it can have on women, because, over 1 in 3 women can attempt suicide. I mean, it's a severe, severe condition. So I don't think how much it can affect a woman is taken seriously. And I think it's because women naturally maybe want to try and mask that, the rushing around syndrome of having to deal with work, deal with, you know, children, elderly parents, everything. They try and mask it very well. And so they might not be open and honest. And if they are, it's not being listened to properly. So I think with the barriers is like the lack of understanding of the impact it can have. So it's not just about asking about the hormonal cycle, it's understanding the impact on that person physically, mentally, but also the impact of the society around them. So how's it affecting the work? How's it affecting, the relationships and their social circle? Because it's PMDD doesn't just affect a person, it's the community around them, isn't it?
Definitely. And actually, just going back to when you mentioned that obviously men get hormones too, I kind of want to pick your brains about that as well. And I think you mentioned this in your TED talk. The difference between women, obviously, men get hormones, women get hormones, but the difference between the cycles. Can you tell us a little bit more about that? Because I don't know much about it.
Yeah, so I mean, we all need hormones to survive. So this concept that it's only applicable to women is completely a myth, because men have hormones, and they have cortisol spikes, they have progesterone as well. It's just produced from not their ovaries but the testicles. With women, typically they will have a 28-day menstrual cycle when they're having their periods, and then obviously when they stop the periods they don't cycle anymore. But men will have a cycle, but it's just a 24-hour cycle of their testosterone hormones, whereas women have a monthly hormone cycle. So they're the main differences. But because women are quite complex in the way that they do have this beautiful hormonal cycle, it makes it very difficult for them because there's quite a lot of menstrual cycle variability. In clinical studies, typically men and mice were included because it was just easier to research men and mice. And then we've got all these clinical studies that aren't really relevant to women, the findings, because they've never been done on women. And so there's so much to be done around women's health cycle and research to see how different things impact them. Because, even doing my PhD now, I'm very aware that looking at different parts of menstrual cycle is an added confounding factor, if you will, to causing variability in a study. So that's why typically men who don't have that 28-day cycle but a 24-hour cycle, it's a lot easier to kind of study variables. So I think there's so many intricacies with women's health, but I don't think we can just kind of shoehorn women into being small men, which, Stacey Sims talks very much about. Can't just presume that if it's okay for a man, we just need to reduce the dose and do the same for a woman.
Yeah, definitely. No, that's really, really interesting, actually. Now I want to pick your brains about your book,
Mhm.
Happy Hormones, Happy You. You emphasize sort of lifestyle roles in hormonal balance. Could you highlight maybe key lifestyle changes that significantly impact hormonal health?
Yeah, absolutely. So lifestyle medicine is very much looking at 6 pillars. And I know it sounds really simple looking at these pillars, but they are so impactful. And there's many women who are actually doing all of this very well and they still suffer. So it's not just a one size fits all, but looking at nutrition, food, you are what you eat. It's food in nutrition is so important to our hormonal health. Our hormones are made from either protein or cholesterol. They're cholesterol or protein based. So having the correct balance of nutrients is important. I suppose in my eyes now, it's not a formal part of lifestyle medicine or the principles, but when we look at what we eat, that's going to affect our gut microbiome, and gut microbiome is so important to our hormonal health because a group of bacteria are responsible for breaking down our estrogens in our gut. So food and gut health is so impactful. And in clinic, I do testing for gut health, and it's very interesting to see patterns of changes in the gut and how that can affect hormones. Because we talk of hormones and think of sex hormones, but serotonin as well, that's made in the gut. A large proportion of it is made in the gut, and so there are other hormones we need to think of when it comes to gut health. And then exercise as well. Now, I think we've had this conversation before. We know some women are very sensitive to the hormones and the way they should or feel like they can train at different phases of the menstrual cycle. At the minute, we're still lacking evidence to completely confirm how we should be advising people. But everyone's so individual that if they feel that they're struggling, it's very much just being aware of that and what is right for them. So I do a lot of tracking, mainly because I'm able to see how I react to exercise in my luteal phase. I'm not great at exercising in my luteal phase. I need to do more walking, and that's reflected in my metrics. So, but exercise is a factor, sleep as well, which is really, really important. People just presume lack of sleep is, a badge of honor, when actually a lot of our hormonal processes balance out during our sleep, and lack of sleep can really impact things. And it's like a chicken and egg. If you've got problems with progesterone or hot flushes, for example, when you're near the perimenopause and you struggle sleeping, that's going to then have further impact on your cortisol, your appetite, nutrition, your gut health. So they're kind of all related. So talked about nutrition, exercise and sleep, they're all related. And then mental health. So, there's no health without mental health, and your physical and mental health are linked. So we've got our physical symptoms, but our mental and psychological state's so crucial. And we know that, like I've said, PMDD affects physical and psychological symptoms for women. Toxic exposure. So there's a lot more work being done around exposure to kind of environmental toxins such as BPA and other toxins. There's a chapter of this in my book, very much trying to broadly talk about being mindful of the different toxins and how they can impact our hormones, because some of those can act as xenoestrogens, which can increase that bucket load. And then also positive psychology, which is just looking at, our purpose and looking at around factors like that, which can be really important, especially when women are in work and they're feeling bullied and they don't really feel like they've got a purpose. That can affect their cortisol and stress hormones. So all those lifestyle pillars are really interrelated, and they're very much related to your hormones as well in a bi-directional way. So your lifestyle will affect your hormones, but your hormones can affect how you lead your lifestyle as well. But the thing I find the most is, even though as a doctor I know exactly what I should do and I tell my patients what I should do, it's the doing of those 6 things.
Yeah.
It's the actual behavior change and the actual changing of those lifestyle pills, which can be the most trickiest thing, because we all know we should eat well, we all know we should move, but what's stopping us? So I do think a lot of coaching and behavioral and psychology work is needed to address people's why they want to, motivation really, to see why they want to change and how we can make that change.
I think that's a really good point, actually, because I think if you're not in the luteal phase and you've just come out of it and it's been hell, and you go, right, okay, I'm going to take all these steps to make sure that the next luteal phase isn't so bad. But then the luteal phase comes round and you've got no energy, you're exhausted, you're burnt out, and you just can't find the strength to make all these really big changes. But those 6 sort of pillars that you've mentioned are really, really interesting. And I think there's definitely something in each of them that people can implement into their lives to make things just a little bit easier. If you were going to give advice for individuals struggling with PMDD, maybe from each pillar,
Mhm.
what would that be?
So because I do a lot of root cause care and very much look at what's driving things, I would say trying to reduce inflammation is one of the key things. So with nutrition, everyone's got their own beliefs, own wishes, whether they're vegan, vegetarian, whether they eat meat. But all I would say is unprocessed, varied food, which is supporting the gut microbiome. So like the Mediterranean diet, for example, is very anti-inflammatory, high in polyphenols, really, really support the microbiome. So nothing extreme, because extremes where you're cutting out certain food groups, we do need all the food groups and fiber, especially, which is a carbohydrate, for gut microbiome health. So I think with nutrition, it's just being mindful of that. And obviously, nutrition can affect your thyroid health. It's not just about the sex hormones, it's thyroid as well. And thyroid issues can mimic PMDD, especially that severe exhaustion. So it's important to, if you're wanting to having tests, just getting some baseline tests and not guessing how you're feeling, not that assumption that it is just related to your periods. Is there an underlying anemia? Is there an iron deficiency? Is there a low B12? Is it a thyroid problem? So nutrition wise, I would say unprocessed varied food, 30 grams of fibre, 30 different plant foods a week. Exercise wise, I think just sedentary is the new smoking, so just getting some movement in. How, I'm not a runner, but moving is good for me in whatever way is good for someone. However you want to do that movement, whether it be walking, running, strength training, Pilates, yoga, just walking the dog, anything, just get that movement in. So this isn't just general advice for kind of athletes, but for the general public, I would say kind of exercise wise, getting movement in and making sure it's varied in the different modalities that you're doing. So not always cardio, not always, but strength training is very important for muscle health. And then I would say for sleep, 7 to 9 hours. Try and avoid blue light before bed, which can be difficult when people are watching Netflix. Staying off your phones, and 7 to 9 hours. And one thing about sleep, which is being talked about a lot more, there's a lot of more research, is consistency with the timing of your sleep, and actually that being really impactful as well. So, actually going to sleep at the same time and waking up at the same time, there are benefits being shown in studies of that to your health as well. So not just the amount of sleep, but the timing and consistency of how you're sleeping. And then with your mental health, I think it's just making sure that you are taking care of your mental health and giving yourself some self-care. And it's not just about everybody else, it's about looking internally at yourself. And talking therapies aren't for everyone, or talking, but there are modalities out there which can help with people's mental health, and not thinking there is a stigma related to it. So just talking and having that conversation. Positive psychology, I mean, for me, moving jobs was one of the biggest things and the best things I could do. One thing I would say to people is find your purpose and try it. You don't just stay in a job because you feel like you have to stay in a job. There are options, there are choices, and don't feel like, you need to have that positive psychology. Oxytocin is released when you're feeling happy. That can have a positive impact on all of the hormonal cascade. So being in a negative environment can have such a negative impact on hormones. And then toxic exposure, I think my advice with that is you can't wrap yourself up in cotton wool, but it's being mindful that there are lots of environmental exposures out there, whether it be, pans, with non-stick pans, just moving towards stainless steel, BPA, moving away from plastic bottles, moving to more sustainable kind of materials, utilize filtered water, though, just looking at small actionable steps that you can do in your daytime. And in my book, it does explain it in a lot more detail for why it's important. But I would say all those things, I think with lifestyle, you're never going to notice something straight away with it, but it's the 6 areas over time that can have such a compounded impact. It's like the compound effect of anything that you do. Same as saving money. You save a little bit every single day, and after the year, it masses up to a large amount. It's the same with behavior change. Doing small things across lots of areas over time will have an impact. People will notice those changes, but it's a marathon. It's not a sprint with it all.
And it's about persistence, really, and building habits take time, don't they?
Mm-hmm.
It's actually really interesting before when you said that changing jobs and like changing your environment can massively help, because actually that's something that I found as well. I changed careers, and the difference in I mean, I still have PMDD, but the difference in my PMDD symptoms was huge.
Yeah.
And I always found that prior to changing careers, at every luteal phase, I would think, right, I need to quit my job. I'm going to have my notice in and quit my job. And actually, I should have really taken a step back and gone, why do I keep thinking that? I'm obviously not happy. That could be really impacting my symptoms. The same as if someone is wanting to end their relationship every single month. Maybe they should take a step back and really look at their environment and see, maybe they're not quite happy as they are, and a change has got to happen. So, yeah, I think that's really interesting. And I think those points are amazing. And definitely people should read your book to find out more about it, because it sounds super interesting. Um, Now, I know obviously this is all about PMDD, but you are, of course, presented with patients with perimenopause or menopause. So I'd like to know a little bit more about that, because I'm sure some of these listeners will experience that too. So, what strategies do you suggest for women navigating perimenopause and menopause to maintain sort of optimal health and well-being?
Well, the biggest things I think we can do is educate women. And that's one of the reasons why I joined the charity, because I want healthcare to be accessible to everybody, and I know we've mentioned the NHS is a great service as a sick healthcare model. But for people to educate and empower themselves, there needs to be a platform. And that's what this podcast is aiming to do. It's accessible internationally to everyone from all walks of life, but also people not just struggling with PMDD, but carers of PMDD as well. So, because I don't want to widen health inequalities, yes, I do have my own clinic, but that's why I'm so conscious everyone should be able to access this. And this is why I wrote my book as well. It's like a low cost resource that people can access. So what I would say is education. So understanding and having hormonal intelligence of what's going on. So your periods, if you have normal regular periods, are quite there's a nice rise and fall of them every month. But in puberty and in the perimenopause, the waves and the changes are quite erratic. And that's why people with PMDD can really struggle in that perimenopausal phase. And a lot of women, when they're pregnant or they've gone through the change and the levels are static and more stable, that's when symptoms improve. Because when I went through the medical menopause, my levels of hormonal changes, there was no fluctuations there. I wasn't having the fluctuations in the hormones, and therefore my symptoms improved. So typically women feel better when they're pregnant. They feel the best they've ever felt. When I went through the medical menopause, there was no cycles, so I felt more stable in my response to my hormones. So understanding that in the perimenopause those changes can happen, and it's just seeking advice and help and seeing what's the right management, because everyone's different. Everyone wants different management. Don't be afraid of like reaching out to your GP, and if asking for a second opinion if needs be, asking to see the women's health specialist within your GP. If seeing someone privately is an option, then having a look at who's available and if they align with your values, and seeing someone to be able to assist you with how to navigate that process. But that's what I would say, is just being aware that there are going to be changes in their perimenopause, which fluctuate and will change over time as well. That's why people with PMDD do quite struggle with the perimenopause. But there's also a lot of interesting research about PMDD and ADHD as well. And there's so much going on because of those hormonal fluctuations. So, and I've mentioned my interest in lifestyle, but the way that people present is a mixture of lifestyle and genetics. So I'm very passionate about looking at people's genetics to see how we can improve pathways and navigate those potholes to help people through vulnerable times. Because perimenopause is what people will describe as a vulnerable time in your health. There's more people that get immune system problems, worsening of symptoms. People get new diagnosis of thyroid. They can get lots of conditions that can arise because it's a vulnerable time in our health. And knowing that, it's just being mindful we need to bolster your health at that time, so that we're not waiting till you get thyroid problems. It's putting steps in place to prevent that from happening.
Yeah, that's really good advice. It's being super aware of your own body and knowing that everyone reacts differently, don't they? And I suppose going back to your advice before of getting the checks of your body and sort of hormones and everything like that, how would people be able to do that then? Are they able to go to the GP and book in some tests just to better understand how their body's working? Is that something that's available?
Yeah, so there are well woman checks available to people if they hit certain age criteria. If sometimes GPs, like I said, because it is more of a cost resource, it's has to be, resourcing in the terms of cost is an important thing in the NHS. So like they might do, like say, a blood count and a thyroid, but your blood count might not look, it'll check your blood cells and check you're not anemic, but it may not look at your B12, your folate, your ferritin and your iron, because usually you wait and see if you're anemic, and then at that point you do those tests. And it's the same with thyroid testing. A lot of practices just check a TSH and a T4, but the active thyroid hormone is T3, and that's not routinely done. So it's working with your GP as much as you can, but there are so many affordable places people can go for at-home testing. And there's people I see with different budgets, and I'll always say to them, right, if this is what you want to do, this is the best place. I'm very mindful it can be very costly to see people privately, but if people are on thyroid medications with PMDD or without, and they're not feeling right, and the bloods are normal, but they've never had a T3 checked, I would want to know what my T3 was. And it's just, I think it's going back to basics with it all. We can do lots of complicated tests if we want, but actually it's going back to basics with it all. You don't need blood testing for perimenopausal diagnosis or even for a PMDD diagnosis. However, there are factors such as iron deficiency, problems with methylation that can worsen people's PMDD symptoms. And I just think we're so far away from having all of that looked at and being part of guidance. I think there's such a long, long way to go. There's so much that we can do. Just because it's not within the clinical guidance that we should be checking those things. But yet I see women improve when we do look at those things and we implement management, because they're wanting to do that. They're very aware that it's not part of guidelines. But if we do that and they improve, they're wanting to be proactive and preemptive rather than wait till they're at the crisis point and needing to have a hysterectomy. I'm not saying that that's not the right option for some people, because it might well be, but it's just for people who want to explore their options. There are options, and I think it's keeping people safe is important, but it's knowing that you're not alone and there are conversations you can have with people who can help.
100% couldn't agree more. And I think I can imagine many people with PMDD who do go to get help and get support, and they are sort of given the option of taking the pill or, in urgent cases, a hysterectomy. It's really scary, it's really daunting, and it's obviously life-changing. But that's because they're not aware of actually there are so many other options. That's due to lack of awareness, which is what we're working hard to do. But yeah, it's just tapping into those other options before taking something that actually might not even work for you, and just being aware of those options out there. So yeah, that's really valuable. Finally, as a trustee and ambassador of the PMDD project, what key changes or advancements do you hope to see in the PMDD world?
So I think we should do another podcast actually at some point about treatments, because I think one thing I see amongst specialists is that PMDD is an issue with, because we don't know the root cause. There's it's multifactorial, and there's lots of postulated theories. Some people say it's a progesterone sensitivity. That might well be the case for some. However, progesterone therapy and body identical progesterone can and has been used in women successfully to treat their PMDD. And that's not currently, well, cyclogest is part of guidance, for PMS, vaginal, cyclogest. So I think what I'd like to see is more research and funding around the body identical hormones to see how we can utilize those, because we have got no long-term real studies looking at that. But there are a lot of women out there that do improve with that treatment. Whereas I think people are scared to utilize that, when actually that can be the treatment and effective treatment for a lot of people. And that doesn't necessarily impact ovulation. For me, trying to keep people ovulating for as long as possible so they're exposed to their own hormones for as long as possible so they'll get the benefits of the bone health and the cardioprotective benefits is important. So what I would say is I would like to see more advancement and research and funding into various therapies, and even more holistic supplemental therapies. There has been some work done on, chasteberry and, the more, some supplements, and there is weak evidence to suggest perhaps it may improve. But again, it's weak evidence, and I'd like to see further research into those areas, because I think we should be looking at it from a 360-degree angle.
Amazing. That's such fab advice. And I think really interesting to hear your perspective, as a medical professional, as a doctor, but also someone who has PMDD. So yeah, thank you so much. I think we should definitely do another podcast. I think I'm sure people listening have got so many questions as
Well,
well.
yeah,
So
that would be good.
maybe if you're listening to this and you've got a couple of questions or you want to find out a little bit more about particular treatment types, submit them and we'll definitely have you on again for another podcast. But yeah, no, thank you so much, Dr. Milli. It's been an absolute pleasure hearing more about your insight and just, journey in your career. So thank you so, so much.
Thank you very much for having me.
Take care. See you soon, guys.
Bye.
Bye.